Good morning, everyone. Thank you for joining us today. It is Friday. Friday. Yay. It's also Powwow weekend, as I was just mentioning. We're going to go hang out, have a good time. Um, so, my name is Angie Sanchez. For those of you who have not joined us this week and don't know what we're doing, I am a PhD student at Michigan State University in the Department of Geography, Environment, and Spatial Sciences. And my research focuses on increasing access to breastfeeding support resources in Indigenous communities. So I applied for a grant um, to basically bring the Indigenous lactation counselor training to Michigan to 6 different Indigenous communities in Michigan. So we are in the middle of doing that part of the grant, but in addition to that, I also wanted to uh, give an opportunity in some way to educate non-Indigenous folks, particularly healthcare providers, nurses, doctors, pediatricians, lactation consultants, home visitors, anybody that really has contact with Indigenous people kind of in this arena of breastfeeding, body feeding, and even just birth work in general, just to try to help us help you serve our relatives better. So that is what this webinar series is a chance to learn some things from my two experts in the room, Kim and Cami. So today's session is Ask an Indigenous IBCLC Anything. So if you guys have any questions, please feel free to put it in the chat, or I mean in the Q&A, and we will answer those. In the meantime, I'm going to pass the mics over to Kim and Cami and let them introduce themselves. And just in the meantime, if there's no questions coming in, feel free to just kind of free flow with
Yeah.
things that you've always wanted to
Our
share with.
own musings and rantings
Yes,
about breastfeeding.
yes, have at it. Let's do this.
Okay. Good morning. My name is Kimberly Morsalis. I am a Dene from Navajo Nation, born in Tuba City. I lived in Arizona most of my adult life. I am now living in Northern California, Humboldt County, which is where the Hoopa tribe, Yurok, and Karuk people um, have their homelands. Um, I'm a lactation consultant, doing this work for over 12 years. Started my breastfeeding work um, in the WIC program with ITCA, which is the Intertribal Council of Arizona in Phoenix, and then transitioned to hospital lactation um, shortly after, and then worked at the hospital for almost 10 years. Uh, since I moved, I started doing more community work in my new community with Hoopa families and Yurok families, and do travel more frequently with Cami now, which is amazing and it's been really fun. And recently just received a contract, a 3-year contract with the United Indian Health Services WIC program in McKinleyville, California, and recently got hired as a per diem lactation consultant for a small hospital um, not too far from where I live. So thank you for having us, Angie. It's been an amazing week and look forward to our sessions today. And yeah, thank you.
Cool. All right. Good morning, my relatives. My name is Cami Goldhammer. I'm Sisseton Wahpeton from South Dakota. I live in Duwamish territory, also known as Seattle, Washington. I'm a full spectrum Indigenous doula, a licensed clinical social worker, and an IBCLC or lactation consultant. I actually saw on Facebook, my Facebook memories today, that I sat my IBCLC exam 9 years ago today.
Wow.
So that was my memory. So yeah, I have one more year to recertify. But yeah, I teach the Indigenous lactation counselor training with Kim. We get to travel all over Indian country doing that. And then at home, I am the executive director of Hummingbird Indigenous Family Services. And we have 2 primary programs, Hummingbird Indigenous Doulas and Hummingbird Nest, which is a guaranteed basic income program. But through Hummingbird Indigenous Doulas, I provide lactation support to our doula clients and Native families that need just lactation support as well. So really happy to be doing that work and really grateful to be here. It's been super fun, a fun week.
Yep.
We love our classes. I gotta say, like, I love teaching our
Mhm.
classes, but it's kind of been fun. Like,
Yeah.
we're like, we can get through so much without all the talking and the discussion. And we want to change that, but
Yeah.
it's like,
Yeah.
it is,
Yeah.
it's just really, it's been a really different experience and
Mhm.
a really fun experience. So
Yeah. It's been fun.
anyway.
So I guess I can just address the comment here from Rosemary Gardner. She
Yeah, we
writes,
heard about Rosemary.
yeah, she
She was
writes,
the LC
Bay
in
Mills.
Bay
Yeah.
Mills, and a lot of the moms in our class received support
Yeah.
from Rosemary too.
We heard
And
Rosemary's name
yeah,
all week. So
I think,
yeah.
I was like, anyways.
Yeah. So she says, hello there, my fellow lactation consultants. I have one of the Indigenous Breastfeeding Counselors that attended your Bay Mills class, interested in shadowing me as her clinical experience towards becoming an IBCLC. So exciting.
Yeah.
Yes, I think mentorship is a huge part of, I think, showing of service. And Cam and I, we have had our share with mentoring mentees throughout our career. And one thing I have to say that when it comes to the IBCLC credentialing and becoming an IBCLC, is it is hard to find mentorship
Yes.
and obtain clinical hours because it takes a long time. But also, not only is it can be an expensive career to get into the field of lactation, but what we find is most of the mentorship individuals will charge mentees a lot of money just to mentor. So Cami and I, we've never charged our mentees to have that.
So you're not asking
Yeah.
us, Rosemary,
Yeah.
if you should charge or not, but we're just
We're just
telling
sharing.
you our philosophy and beliefs on, on this too, that we believe that this is an important service. As an IBCLC, it's important, as a social worker, I was taught each one, teach one. That, it is a part of our work. It's a moral obligation as social workers to raise up those baby social workers, right?
Yep.
And share what we know. And so I've been a social worker now for 17 years. I started when I was 8. It's so weird. But anyway, isn't it amazing? I was so smart as a
You
child.
were such a great social worker at 8.
So anyway, but and as long as I have been doing that and could have a mentee, I have had one. There's been a couple of years where I haven't been able to have a mentee because I've been independent and didn't have like liability insurance. There were certain rules as a practicum instructor that I had to have that I didn't have when I wasn't part of like a formal institution or organization. But yeah, it's something that Kim and I have found missing from the lactation field, is that kind of obligation that each of us, that each one teach one mentality. And that has resulted in a very homogeneous profession that is mostly upper middle class white women, because of the way the pathways are set up, make it much easier for certain people to become lactation consultants. And the pathways, like both Kim and I, neither of us could become IBCLCs today if we were certifying now with our same, credentials and foundations that we had 12 and 10 years ago, right? Like we are 11 and 12 and 9 years ago, I guess. We would not be able to be IBCLCs today. And that's a problem, and so we have to think about, like, as a field, if we want to increase breastfeeding rates, if we want to make sure that community gets support, then that means training and supporting people in becoming LCs. And pathway 3, that mentorship track, which is what Rosemary has been contacted about, is the way to do it. That is going to create the best, most skilled lactation consultants by far. and it's going to create a more diverse population. So it seems like you're excited about it, and that you're, maybe you're in, or you're definitely considering it. But I don't know if you have any questions, Rosemary, because I'm not sure if you've mentored anyone before, but if you have any specific questions about mentoring and being a Pathway 3 mentor, both Kim and I have done that. And so we're happy to share, any specifics around like how to get started. The one thing I'll say, because I made this mistake with my my mentees, is that with Pathway 3, you actually do have to start. You have to inform IBCLC, which is our credentialing organization, of that partnership.
Yes.
And so I made that mistake with my first time mentoring. I didn't know we had to notify them and send in paperwork letting them know. And so my mentees had to switch to Pathway 1 because their hours that we had started were, and had been doing for like 8 months, didn't actually count toward Pathway 3. And so they had to switch, and so that was like a rookie mistake that I made. And IBCLC is not known for being super organized, and, well, I don't want to say that. They're maybe organized, but super clear in the requirements and the expectations. We see that every year when people are wanting to become LCs. They're like, where do we find this?
Yeah.
Where do we, they ask really simple questions. So, like, it's everyone's learning, but that's the one thing I will say. Like, if you decide to move forward with this Pathway 3, Rosemary, like, get the paperwork off of the IBCLC website, fill it out, send it in. There's a small fee of about $100
It's
to send it
$100.
in. I highly
Yeah.
recommend
It's
it.
actually just a one-page
A
application.
one
It's
page,
really
yeah, it's
simple.
pretty simple, yeah. And
Yeah.
then as a mentor who was working and making money, I paid for my mentees application fee. Again, that was just something that I felt was important, but you don't need to. But yeah.
Yeah.
Did you have anything? Because Kim set up a Pathway 3 program in her hospital.
Yeah, I was very fortunate. It was a pilot process. It was going to be a pilot program, and I did it in 2000, and I started in 2019, and it launched in 2020, which the pandemic happened, so we couldn't launch it. However, towards the first year of the pandemic, I was able to have one mentee come in. And the way I set up was, one, I had to make sure I had my support system in the hospital, which would be the charge nurse and the doctors, the risk management department, because they want to make sure that I had the mentees covered by liability insurance. And that's really the huge thing they get concerned about, is liability and HIPAA. And so I was able to get through that red tape fairly easy, and I got involved with the education department, and she was uh, very supportive of the work, because we kind of treated them as like a. I was a. I guess I was like a in my own institution, because you have to be an institution to be in the hospital setting, and so that's what I did. I had to provide a curriculum, an outline, how they're going to learn. What I did, because it was I want to say free mentorship, the only responsibility I had the mentee do was the application, the liability insurance, and their fingerprints. And compared to that fee, what they would have to pay outside of that, to any university or any, in my area, the mentorship programs around my area was expensive. It was like $5,000.
Yeah.
And so I offered the mentorship to the BIPOC applicants. So I had three young women come in and do the work, interviewed about maybe 10 inspiring LCs. And yeah, and it would have, I think it's still going in Phoenix. I'm not sure, but that was the first mentorship program in a hospital setting in Arizona. And it was, it was going to be something that could have been sustainable. And then in the process, I was including the WIC program, the state WIC, to come in and also do more peer counseling support with the hospital, because a lot of our families were Spanish speaking families, and I didn't speak fluent. I spoke some, but not enough to, provide the um, cultural component of patient care. And so most of the WIC peer counselors I knew were Spanish speaking, and that's what we needed. So yeah, I think it's very possible that we can make these changes
Yeah.
internally and gain the trust of directors. And I think they were going to have me do a presentation in front of the board, which I was totally happy to do that. Um, but it moved forward, and it was pretty easy, and it was a good program. So, but yeah, if you have any questions,
Yeah.
Rosemary, please reach
Yeah.
out.
Because if I remember correctly, Rosemary was a WIC, worked for WIC
Mhm,
as an
I think so,
LC.
yeah.
You can correct us if we're wrong, Rosemary, but there may be some additional, things that you need to do, similar to what Kim had to do in the hospital. It's a little different when you're a private practice LC.
Mhm.
We can do whatever we want, like it's nice and free out here. But if you're, if it's with WIC and with WIC clients and things like that, then there might be a little bit more red tape that you have to go through, which is what Kim worked on, for her hospital.
Yeah.
So yeah, just something to think about there.
Yeah. Yep.
Cool. Um, yeah. So
How many
Mark, do you
people?
want to see if we have any Q&A? Okay, no. So we're wondering if there's any questions. This session is, ask an IBCLC anything. I'm just wondering if there's any folks with specific questions. I know Cedar took our training in Minnesota, and if I remember correctly, Cedar was pregnant at that training and has
Mhm.
since had a baby. So maybe you have questions, Cedar, about your own baby. But yeah, or if other folks have any specific questions for us, we're happy to answer anything. So yeah, I'm glad we got to talk about mentorship though.
Yeah, yeah, because I think that's one of the things that I mean, it always happens in our course. There's always at least one or two people wanting to do the mentorship program or do the IBCLC. I think who Rosemary might be referring to is Renell.
Yeah, I
Renell,
think
yeah,
I think that is, yeah.
yeah,
There's a
Renell.
couple of folks in there,
Yeah,
but I know Renelle was most
yeah,
motivated. So
and she has, I think, most of her stuff done already. So I think like
Yeah.
the college courses and yeah, just the clinical is a tough one. That's the hard part.
yeah, it is. It's hard to get it. That's for sure. We both, like I said, Kim and I both got really, really lucky.
Mhm.
So yeah.
So Cedar,
Ooh, yeah. Cedar says our biggest breastfeeding struggle has been no bottle. Just wait all day at daycare for mama. Yep, that's a common.
yeah,
Yeah. So
I
we
love
we
that.
can talk about that because we actually probably won't have a solution for you there, Cedar, but we can do some like a little bit of guidance for the like shoulda, woulda, coulda stuff for folks, for future guidance for like help supporting other families, because this is actually a pretty big challenge. I just answered a question in my like neighborhood Facebook group about this because someone had mentioned posted my Facebook group about their 6-month-old who and she was looking for breast
Yeah.
milk that didn't have, so she had decided that she had excess lipase. And lipase is an enzyme in human milk that sometimes we make a lot of. And once the milk is pumped outside of the body, that enzyme kind of overproduces and it can result in making milk taste really bad.
Yeah, it looks soapy and it smells like rotten eggs.
Yeah. And it's like really gross. And
And
lots of
yeah.
babies are fine drinking it. Like it's not bad, it's not rotten, but so for folks out here, like if you have someone say like my milk is spoiled or my,
It
I offer
smells bad.
I
I
offer
just
my baby
pumped
my
it.
milk and
Yeah.
it's rotten or something like that, go to it's excess lipase. Like
Yeah.
human milk, literally I've left milk in the fridge for like 6 months and it just turned to butter and never smelled bad. Like human
Mhm.
milk just does not go rancid the way like cow's milk does. So so she said, she has this 6-month-old baby who isn't taking isn't taking her bottles of pumped milk. And so she was like looking to trade basically her milk with excess lipase for milk that doesn't have excess
Mm-hmm.
lipase, right? And I was, I read it and I'm like, well, like, has the baby been taking the bottles previously? And then kind of got to that this was a 6-month-old that was just being offered a bottle for the first time,
Mm.
which is basically the equivalent of giving a baby rotten milk for them. Like a
Mm-hmm.
6-month-old is not going to take, I mean, they're just not going to take a bottle, like
Yeah.
after previously breastfeeding exclusively for 6 months. And so, and this is something that definitely comes up a lot when people are exclusively
And they're staying
breastfeeding
home.
and they're staying home, and like it's amazing that we have time off, and having that time off, and it does get to a point where it's just so much easier to breastfeed. And if we're going to be separating from our baby at any point, we actually really do or should be offering a bottle much earlier
Mm-hmm.
and consistently giving it every day or
Yeah.
every other
Yeah.
day.
Yeah.
So it's one of those things that like I really recommend offering the bottle between 6 and 8 weeks. Sometimes even earlier. That's assuming someone's going to be returning to work around 12 weeks. But if
Mm-hmm.
you're returning to work at 6 weeks, then we need to be offering the bottle sooner. And then just consistently, like every day, offering it once a day. Even if you're home and you're breastfeeding, just kind of
Mm-hmm.
keeping that practice, because you'll have babies love breastfeeding. And so once they kind of hit that 8, 10, 12 week mark, they get to choose if they're going to suck on
Yeah.
something or
Yep.
not.
Yep. I wish someone told me that with Nakaya,
Yeah.
because she did exactly what your baby's
Nakaya.
doing. Cedar is that reverse cycle where I was pumping and she didn't take a bottle at daycare. And so my babysitter called me and she's like, Nakaya's not taking a bottle. And she's like, I know she's hungry. And I'm like, okay. And I didn't know what to say. I'm like, well, she'll be fine. I'm
Yeah.
like, okay, she'll be fine. She'll be fine. So when I would get home, she would nurse all night. And then during the day, she just wouldn't eat until I saw her. So she was a pretty healthy, chunky baby, and I wasn't concerned about her losing weight. She just preferred it that way. And I didn't know she couldn't take a bottle. And so at a certain point where I couldn't give her a bottle, I just offered them a sippy cup,
Yeah.
because by then you don't have to, if they do get on a bottle, which most likely will not happen, they can just get on a sippy cup and you don't have to worry about
Yeah.
the bottle or weaning off a bottle. But yeah, it worked out. I mean,
Yeah.
I didn't know, like, yeah,
Totally.
until I
Is
became a
like,
lactation kid. So I'm like, oh, they don't take a bottle
that's what
when you
happens.
don't
Yeah.
offer it. Yeah.
Yeah. Yeah. And my second, it was the same thing. With my first, I returned to work pretty early. So about 7 weeks postpartum. So we did offer a bottle earlier. But with my second, I was home for 18 months. And so I actually like offered a bottle once at probably like 5 weeks or six
Mm-hmm.
weeks, and she took it once. And I was like, cool. Also, this was before I was an LC. And then, I I took a doula training. This is like almost 10 years ago. I took a doula training and it was 5 days, and she was about 9 months old and one like refused to take it.
Mm-hmm.
And I was like, oh no, and that's where I had learned about this too.
Yeah.
But the interesting thing, and Kim mentioned reverse cycling, is
Mm-hmm.
that's what what babies do. So breastfed babies are completely capable of, we call it reverse cycling. So basically, if we had a 4-month-old or a six
Mm-hmm.
month old or a 9-month-old who is sleeping 12 hours a night, right, or 8 hours a
Mm-hmm.
night, we wouldn't worry about that. So instead, these babies just reverse cycle and they do their 8 or 12 hours of not eating
During the
during the
day.
day,
And
and they
then
eat
throughout.
overnight,
Yeah.
right? So it's exhausting. So like
Mhm.
Cedar is probably up, nursing throughout the night and things like that. Which, is, as long as you're not like a brain surgeon or a pilot, I suppose you can like function,
On 4 hours of
like,
sleep.
like with, like it's like, me being like tired was not life threatening,
Yeah.
kind of thing. So, not everyone's job allows you for you to do that, but, it's really common for babies, breastfed babies, to just go like they will take in the bare minimum. So they might take
Mhm.
like an ounce or
Yep.
a half an ounce or something like that, or they won't take anything at all, but they're
Yep.
fine. Like they're not hungry. They're not fussy. They might get a little fussy as it's closer to you getting
Yeah.
home,
Because they know.
kind of because they know
Yeah.
it's close and you're going to be walking through the door or whatever and nurse. And so they get a little like, ooh, but it is something that's pretty normal. And kind of the only way to prevent it from happening is offering a bottle early and offering it consistently until it is time that you go to work.
Yeah.
So
Yeah.
yeah, hang in there, Cedar.
Yeah.
It's, your baby loves you and
Yeah.
it's awesome. But yeah, definitely like something to talk about with families. I run into this a lot in Seattle because um we have we have paid leave in Washington state that we pass. So pretty much every parent is able to take paid time off after they have their baby. So they're going to be taking 12 to 16 weeks off. And then we have a lot of, we're kind of like Silicon Valley North.
Mhm.
So we have a lot of companies with really progressive paid leave policies where I have some parents that I work with that are getting 6 to 12 months off of work. And so they, they're like,
Mhm.
why bottle feed, right? Like I'm just doing the breastfeeding thing. And then it's like they hit, time to go back
Yep.
to
They're
work
like, oh
and
shoot, my baby won't take a bottle. Yep.
totally. And so it's something that I definitely like and talk to parents about and make sure they want to know. And I'm like, if you ever want to separate from your baby, right? And it's hard to imagine that in those first 2 months or so, like
Mhm.
I'm never going to want a baby
Yeah.
to be away. But if you ever anticipate yourself wanting to separate from a baby, then it is going to be something that'll be good to do.
Yeah. Because my mom would say, Micaiah's crying and she won't take a bottle. Like it was always like, people complain,
Yeah.
family
Mhm.
complain to take care of your baby. They
Yeah.
want no one's to take care of your baby.
Totally.
Yeah, it was
I'm
hard.
so thankful that Frankie took a bottle because I see this come up a lot.
Yeah.
Is my
Mhm.
baby won't take a bottle, and especially I'm in some of the Facebook like
Yeah.
Mhm.
lactation groups or whatever, or breastfeeding groups, and yeah, there was a time like it was an emergency that we created, but we went to a softball tournament. Frankie was like 3 months old because it was end of summer and or early September, and um it was an all night softball tournament that we didn't know was all night.
Oh,
Yeah. So
that's
like we were
fun.
having games at like 2 in the morning
my
and 5 in the morning, and it was all night. And we went there and I'm like, oh my gosh, I cannot keep Frankie out here all night because it was early September, so it was like
Mhm.
fallish
Yeah.
weather. So it
Yeah.
was a little bit cold. Um, so anyway, my mom just happened to be camping down the road about an hour and a half from where we were because we were way like close to the Indiana border. And mom was camping, and so she took him. It was
Mhm.
so his first time camping, 3 months old, but luckily, he was able to. He took a bottle. Like that wasn't even a
Mm.
consideration for me. Like, oh, here you got to take Frankie, and you got to keep him overnight because
Yeah.
Mhm.
I'm going to be out on the ball field all night long. And so yeah, I never even really like. Thankfully, that wasn't an issue for me, but I see it come up so much, and
Yeah.
I imagine it's super frustrating for
Yeah.
mom and people because of the stress part, like the
Yeah.
complaining, like
Yeah. You can't go anywhere,
yeah.
like, oh, I take my baby,
Yeah.
Yeah. Yeah.
Yeah. So yeah,
It is hard.
yeah. It took some time, but we got through it. But
Yeah.
you just go through it and
Totally.
do little things to
Yeah.
try to get them to take a bottle if they can. Like
Yeah.
I know offering it from another family member can be easier
Totally.
because babies could
Yeah.
definitely smell mom's milk. I mean, as soon as they get on your chest, they're like looking and sticking their hands in there and wanting to nurse, and
Yeah.
they won't take a bottle from you.
Yeah. I remember Eric texting me a picture of JoJo and she was like, had the bottle upside down, sucking on the bottom of it. And he just wrote, I don't think she gets it.
That's so
like,
cute.
I mean, she just had no idea
Oh
what
my
to do.
gosh.
And at that, she was 9 months old and 27 pounds. And so there is actually something like with, sometimes like these babies with lots of like high weight gain
Mhm.
too, it's easier. Like I find that they're better at reverse cycling too. They
Oh
don't
yeah.
need, I don't know if that very well might not be like
Yeah.
statistically true, but it's just what I've seen that kind of babies that do reverse cycle tend to be
More fluffy.
Yeah, like that's pretty
Oh,
much
that
it.
makes sense because there's more fat at
I think
night, right?
so.
Like there's
Yeah,
more,
I think
yeah.
so. Yeah. So it's like, is it, yeah, what
Hmm.
chicken or the egg kind
Yeah.
of thing? Like, are they able to do it because they have more fat, or are they fatter because they're nursing at
Yeah.
night? Because that's when we have like the fattiest
Yeah.
milk. Yeah.
Yeah. That's interesting.
Super interesting. All right.
Um,
Or had a comment
yeah.
and then a question.
Yeah.
Ooh, which you and I
So,
have talked about.
yeah,
So
because I
let's,
texted you,
you
right?
did.
Yeah. Yeah.
Yep. Yeah. Do you want to read?
Yeah. I can read the top one. Now nation is so vast, and I don't think there is a count of how many IBCLCs we have, or if they are actually practicing, or what area they are from. And a majority of our people do not know what an IBCLC is, which is pretty much common.
Yeah.
It was so Oh, it was so great to enhance our
Yeah.
access and get more Native women to become IBCLCs. Hats off to you too, for where you are today, and hope to have more.
Mhm.
Thank you.
Thanks, Laura. Yeah.
Yeah.
I think we actually don't know how many
Hmm.
Native IBCLCs there are, because IBCLC, which is the International Board of Lactation Consultant Examiners, so that's our credentialing agency or organization, they actually they don't do any demographic data,
Hmm.
which is a huge problem and something that I've been complaining about for approximately 10 years now.
Hmm.
And it's something that, like, I don't, well, I have a feeling that they're not doing it because they're pretty embarrassed by what the data will show. So it's just easier
Shattered.
to
Yeah.
not do it. But we think there's
Hmm.
about 20 native IBCLCs. um and that's just based off of like who we know, who we've
Hmm.
connected with. It seems like every 5 years I'll be at some conference where someone will come up to me and be like, oh, I'm,
Hmm.
this tribe in an IBCLC. And I'm like, oh, cool. But that's really few and far between. Kim and we're probably in the first five.
Hmm.
Um, and then most the ones that have come since then have been folks that took our training.
Hmm.
But I think that I would guess that probably anywhere from a quarter to half of native IBCLCs are Navajo.
Mhm.
And and I just think it's because we talked a little bit about this yesterday when Aura was on. Is Navajo Nation was just really ahead of the game when it came to
The peer counseling
the peer
program,
counseling
the
program.
workforce place
Totally. Yep.
policy. Yep.
Yeah. I mean, I
Mm.
think about like Aura, Amanda, the peer counselors
Mhm.
that you were part of. I remember
Mm.
seeing like the picture of you
Mhm.
guys, and there was like five of you, five or
Mhm.
six of you
Native health. Mhm.
at Indian Health in Phoenix, and it seems like it was around the same time as Aura and Amanda started
Mhm.
too,
Yep.
right? Like, and so yeah, I just think that like that alone made such a huge difference for being able to become an IBCLC in Navajo Nation. But again, like it's just gotten harder and harder to become an IBCLC, and not in a sense that it's harder clinically, because I will tell you, I mean, Kim and I say this about Aura and Amanda all the
Yeah.
time.
Yeah.
Like they are some of the best LCs you will ever come into contact with. Like they're so smart and so skilled. Um, and so it's not like they couldn't
Pass the
pass
test.
the test
Yeah.
or provide solid
Yeah.
work. So it's not so much that it's harder in that way. There are systemic barriers in
Mhm.
place that have made it harder and harder
Like
for people.
mentoring a
Yep.
clinical lactation
And the
site.
college
Yep.
requirements and things like that. And those are things like I'm not kidding when I say that Kim and I would not be able to be IBCLCs today if we were sitting the exam
Mhm.
today. Right. Most of like the big wigs in lactation, the ones that speak at all the conferences, would not be IBCLCs today.
Mm.
I think about like Linda Smith, who wrote the first exam, was a PE teacher and a stay-at-home mom, like that kind of stuff. And she wrote the first exam. Like she didn't have a healthcare background. She didn't
Mhm.
have health sciences, like that kind of thing. Our sister Liz Brooks, is
Mhm.
a lawyer, an amazing
Yep.
IBCLC, travels, like works as an IBCLC, travels and speaks
Mhm.
at conferences. I mean, there's just a huge list of them that we would not be able to be IBCLCs today because the credential
It's changed over the
is
years.
changing, and they are making it harder and harder and harder for people, especially from the community, to become
Yeah.
IBCLCs. And paranoia will destroy you, but like I gotta say, like, it's curious that as more peers and more people of color became IBCLCs, starting in like basically a big chunk of you recertified this past year,
Mhm.
that
And
that
then,
was the year that they started tightening the
yeah.
ship and making it
And
harder.
I would say that was a year the recertification is, some of us didn't pass
Totally.
because it got harder
Yes.
and it was more clinical.
Yes. Yeah.
So, yeah.
And so there's there's just big issues, I think, there. And and kind of what Aura is saying here is like our people don't really care, and that's true.
Yeah.
Like most people don't know what an IBCLC is. Most of our, in the Native community, what they care about, and this is why I'm like, what I say about scope all the time is our community determines our scope, right?
Mhm.
Like, nobody cares that we're
Mhm.
IBCLCs. Nobody cares that we're not
Yeah.
IBCLCs. What they care about is that we provide compassionate, loving,
Yep.
good support, right? And
Mhm.
like help solve the challenges. And I will tell you, there's a lot of IBCLCs that provide really poor support and don't know what they're talking about, and stuff like that. And that has a lot to do with how we get credentialed.
Mhm.
But there's just huge disparities within the field. And so we're grateful that we're able to do this and that we've been,
Mhm.
able to kind of open certain doors. But, we say this all the time in our class, like in 10 years, like I'll recertify next year,
Mhm.
but when we have to recertify again,
Yeah.
5, 10 years, I don't know that
Yeah.
I will,
Yeah.
like, I don't know that I will because, um, decolonize
Mhm.
lactation. We don't need
Yep.
it.
We
Yeah.
don't need
Like,
it.
need it.
Yep.
That's
But for
right.
right now, we have community members, we have people that we train that do want to become IBCLCs. They do want to work in a hospital.
Mhm.
And most hospitals, you do have to be an IBCLC to
Yeah.
work in them. There's certain things that they want to do that being an IBCLC opens that door.
Yeah.
And so as long as we have folks that are wanting to do that, we don't want to be a barrier.
Yep.
And so it's helpful for us to have it for teaching, because then our course counts towards those
Yeah.
hours, where if we weren't IBCLCs, then it wouldn't be that
Yeah.
way,
Yep.
so
Yeah.
it's just complicated.
Mhm.
Did you have
Yes.
something to say, Angie, or
I forgot.
okay, I'm
I'm
sorry.
I did. That's okay.
Sorry.
Yeah. But
Oh.
do we want to address Aura's question? 'Cause,
Yeah.
yeah, we talked about this.
Yeah. So Amanda sent this question to me that Aura asked. What are your views on providing a pump hand expression? I'm guessing showing like provide a hand expression, how to teach a
Showing.
mom, show mom to a gestational diabetic mom during pregnancy and or immediately after birth, and for how long? There are mixed views on this scenario. Oh, she put breast pumps. So yeah. Um, so I reached out to my colleagues, and I got to go on my phone and see what they said because I don't remember what the rationale is behind that clinically. And I I actually didn't think it was necessary, right? And from what I know, from what I was taught, but what were our thoughts on that?
Well, so I guess the
I'm gonna
first
look at
thing
my
to
phone and
kind
find that.
of the first thing is just
Remember.
kind of talk a little bit about gestational diabetes. So and why someone would be encouraged to pump or hand express before they have their baby or shortly after pregnancy, which in general for most people we would not recommend that. We would say, you know
Hmm. Let
you
things
have your
happen on
baby, like,
naturally.
yep,
Yep.
like nurse your baby, no need to do anything before you have your baby, just nurse your baby after, and that's going to bring in plenty of milk and it's going to be all good, right?
Hmm.
With but we also see with parents with gestational diabetes, so birthing people with gestational diabetes, that they sometimes have a harder time getting like a full supply or some other delays, in
Mm-hmm.
milk coming in and things like that. So some of the recommendation, or some people are being recommended to express in prenatally or get to pumping and things like that right after they have their baby. Um, I'm kind of on the in the camp where I this is I don't know. I'm in the kind of like be cautiously optimistic, where I think I don't feel like there's necessarily anything biological going on inside a parent who has
Mm-hmm.
gestational diabetes that will impact their milk supply. But there are things that we see with parents with gestational diabetes that can impact a milk supply. So one of them is bigger baby, right? So that's, one of the things we see with babies that are born to parents that are gestational diabetic or have gestational diabetes, is that their babies can be big, like big, like 10,
Mm-hmm.
11, 12 pounds, like
Yes.
big babies. And those babies can have a difficult time regulating their sugars too, right?
Mm-hmm.
And so the hospital goes into a protocol typically, and Kim can confirm this on your hospital
Mm-hmm.
policy, with a parent who has gestational diabetes, that baby will, their blood sugars would be automatically, like, routinely
Oh
screened.
yeah.
Yeah,
Mm-hmm.
so they'd be routinely screened. And there's certainly like some mixed inform or thoughts around like routinely screening for anything, right? There's kind of a big push to stop routinely screening
Yeah.
for things because we're finding things that may not actually be an
Yeah.
issue. And this isn't just in babies. I've heard it in like breast cancer, and
Yeah.
that like women are having full mastectomies
Mm-hmm.
without even having breast cancer, but they find, there's something that they were screened for a gene,
Mm-hmm.
and it's like, oh, they have that gene. And so they have their breasts, removed or
Mm-hmm.
something like that. And it's like, well, we don't know if that was going to turn into breast cancer or
Yeah.
not.
Yeah.
Right. And so there's a kind of heard this conversation in the healthcare field just around routine screening. So when it comes to sugars in newborns, there's certainly different schools of thoughts on we should just screen babies that are symptomatic,
Yeah.
right?
Mm-hmm.
And not routinely screen.
Yeah.
And so that it tends to be the way it's supposed to go, except for if you have a large baby or gestational
Mm-hmm.
diabetes, then it's a routine
Yeah,
screening.
so there's a certain protocol that they have to follow depending on how big the baby is. And especially if a baby is like a full-term baby,
Right.
they're pretty big babies. And I think what the rationale is behind that is that one mom may not be feeding well. So to prevent anything interfering with supply. The other is how controlled her diabetes is during pregnancy, which can impact her um, not having the milk transition, so lactogenesis too. So that's where my friend just told me. I was just texting her. I mean, she texted me a while back because I asked her about it, but said she thinks it's delayed onset of lactogenesis too. So babies will get breast milk that they've saved instead of formula while they are waiting for their milk to
Right.
transition
Right.
in. So that's what her thoughts are on.
Yeah. And it makes sense. And at the same time,
Yeah.
like, it's a result of that system,
Yep.
right? So if we have a large baby that is, their sugars are screened and they're asymptomatic, but they test for,
Mm-hmm.
high blood sugar, or right,
Low.
low, sorry, high, yes,
Yeah.
low blood sugar, then they're going to start going into a protocol for that, right? And that might
Yeah.
be like glucose
Supplementation.
formula, something like
Yeah.
that, which can impact the parent's supply, right? So
Because
they're
Mm-hmm.
supplementing, they're nursing
so the
less
lactogenesis is already delayed by
because of the,
these interventions.
yes,
Yes.
yes,
But also moms, her too, how is she able to control? Because when mom has
right,
like diabetes, when she has a baby, there's a lot of complications that can
yeah,
happen where it could have less of her doing a lot of
right,
breastfeeding, where
right,
it's important to get to lactogenesis too to do that. So I think it's just they're trying to prevent
right.
these things,
Yeah.
but I think it's more like a case by case
I think
scenario,
so too. Yeah,
right?
I think in general we should in general, when it comes to lactation, we need to be doing
Yeah.
everything on a case by case
Yeah. Because it's not
scenario,
going to be
which
the
is,
same outcome every
yeah,
time.
like I don't know that I would recommend this routinely,
Yeah.
for every mom with or parent with gestational diabetes.
Because you don't know, they can be fine
Most of
after.
them
Yeah.
probably will be
Yeah.
fine, is the thing, right? Most will be fine. But because we kind of put them on this protocol, and I've seen this happen in other areas too, like preemies, for example, I share
Mhm.
in our class a story of working with preemies that were, well, babies that were born at 36 weeks, 6 days. So one day shy of being full term, and they were just automatically put on preemie protocol.
Mhm.
And it just completely derailed breastfeeding. And these babies were literally, one of the babies, we use her nursing in a video
Mhm.
to show like the perfect first feed and like latch and
Mhm.
sucking and swallowing. Like that's how good she was and how well she was nursing, like literally like a 42-weeker. It was just incredible to see
Yeah.
this little 36-week 6-dayer. But because she was a preemie, she was just moved onto this like routine, like protocol for how they work with preemies, even though both the babies were having no problems around it. And that derailed breastfeeding,
And the
right?
sugars
By
were
day
good,
3,
right?
they were not breastfeeding,
Mm.
and it's
Yeah.
just like, that's the problem. And again, it's easy for me to say this, not working in a hospital system where you have to create, these protocols are helpful to make this system work. It does take a lot to meet each family where they're
Yeah.
at and
Mhm.
everything. And that feels like best practice
Yeah.
though too, is that, we would treat each family as it is.
Yeah. Or did you guys ever ask the hospital why they do that? Did you ask the person that was, encouraging these practices? Did they give you any feedback? Why they were doing it? I'm curious.
It's me. I'm Mark and he's me because he's logged in
Oh.
over there on me and I'm Mark. So it's me. I have a question. But I wanted to
Yeah.
give you
Yeah.
guys time
Yeah.
to
I'll wait for Aura
discuss.
to
Yeah.
come back.
Yeah.
But it's a good question. But I again, I've never heard of any
Yeah.
hospital doing that routinely.
Yeah. And I would just be, again, like cautiously optimistic. It's something that, it's important that parents with gestational diabetes understand the potential
Mhm.
challenges that they may come up against and be prepared for those things. But I I wouldn't recommend assuming those things are going to happen,
Yeah.
because most babies born to parents who have gestational diabetes, everyone's going to be fine.
Yeah. They breastfeed
Like
fine.
most are going to be fine.
Milk is okay.
Yep.
Yep.
So it's one of those things of like, okay, you have this. These are some things to be aware of so that when and if they happen, you know what to do,
Mhm.
kind of thing, but not hey, you have gestational diabetes. Your baby's not going to be able to breastfeed. You're not going to make enough milk. So we're going to make you,
Mhm.
like
Pump.
have you pump and do this and that and the other ahead of time. That's just going to create like a spiral for most parents. If they're already starting out thinking like, I failed my baby. My body failed my baby.
Mhm.
I put my baby in danger, oh my God, that kind of stuff. And it's like, that kind of stuff just isn't worth it to me.
Yeah.
So,
Okay, looks like she did answer.
Yeah.
one hospital does it routinely because they wanted to encourage more breastfeeding, but they didn't have a solid answer if it was working. They they have a diabetes program in that area and purchase the pumps for these moms. Funding was available, so let's do it attitude. Yeah. Yeah. Thank you for that information.
Yeah.
And it's a good question, Aura, because I do think it's probably going to start, it might be something that continues to come up in
Yeah.
other communities.
Mhm.
So, especially in the Native community where we have higher rates of
Yeah.
gestational diabetes. Um,
Okay. This is Kaylin.
Hi, Kaylin.
Hi, Kaylin. I think I worked with Kaylin.
Yeah.
I think me and Amanda did. Yeah. How can I best support mommy, daddy, and baby boy who I can't read the
So, how can I best support mom, dad, and baby boy who both have tongue tied Mark, can you move that over a little bit? I think we're missing a word. Oh yeah. Who has both tongue and lip tie, best feeding position and hold, tips, any tricks, anything like that. All right. Let's talk a little bit about tongue ties.
Our naked baby.
Baby in our breast. Well, oh, I was reading Cedar's comment too, because it sounds like she had gestational diabetes. So Cedar says, for my daughter, she was put on blood sugar screening protocol after birth due to me being
Is it anti-hypertensive?
hypertensive because of preeclampsia. She ended up having low blood sugars and had to be supplemented.
Yeah.
And
That
then-
again, I think that's a case by case scenario because I work with moms who we had to do that, but again, you can't tell what's going to happen in the hospital. So in that case, I would done hand expression, donor milk.
Yeah.
And then we have another comment there, Mark. As soon as you're done, if you can scroll up on that thing so we can see. Another hospital is from Aura. Another hospital was breast was best, but discouraged pumping even when it would have benefit.
Yeah. All right.
A lot of mixed messages.
Totally.
Yeah.
I'm just like, yeah. Yeah. All right. Or seeing history of gestational diabetes and history of preeclampsia a lot. So.
Yeah. Those moms, or I'm sure this is just following up with them and seeing how they're doing with, their stay in the hospital and after, making sure the baby's latching. I'm sure you do a great job. You were on the call yesterday and you said you see like hundreds of moms.
Yeah.
Yeah.
All right. So I guess you can talk about tongue ties. So I'll do a little bit about a little discussion maybe about tongue ties first. So because it's come up a little bit already. So Angie's son Frankie had a tongue tie. Selena had a tongue and lip tie yesterday, when we talked to a parent about, when breastfeeding didn't go well or go as planned, tongue and lip ties happened there. And then I think that's all it's come up, but it always comes up, like it's definitely
last 48 hours came like 4 times.
comes up all the time. So a tongue tie is a tongue and lip tie is when the frenulum under the tongue, so the tongue and the floor of the mouth are one piece of tissue. And around 10, 11 weeks in utero, there's cell death that occurs that separates the tongue from the floor of the mouth. And that cell death eventually stops. And then we have the tongue, right, is separated. And tongue tie refers to a restriction of the tongue. So we all have frenulums. Like that's not the presence of a frenulum is not a tongue tie. What we look for as LCs or providers that are looking at tongue ties is we're looking for, is the tongue restricted? So does that frenulum impact or impede on the tongue's ability to function the way it needs to breastfeed? Okay. It's considered a midline defect because the way we develop in utero is kind of like in this midline. And there's lots of theories as to why a baby has tongue ties or doesn't have tongue ties. We think that it occurs in about 5 to 10% of babies. There's a long history of tongue ties. There's like folklore of midwives having long pinky nails and, swiping under a tongue way back in the day, things like that. And so it's not a new thing. It's just that we gave up breastfeeding for about 150 years. And so now that it's kind of moving back, like kind of coming back, then now it's being seen more often. And as we're, there's just been a rapid increase in the amount of information we have. You have to think about the modern field of lactation is only about 40 years old, or 35 years old. So the first IBCLC exam was in 1985. And so it's still a fairly new profession in this way. And so there's just been a lot of information learned, even in the 10 years, 10 plus years that Kim and I have been doing this. We were taught certain things that are wrong now, right? And so there's just always information changing, but that is something that comes up because there are some providers, and Blue mentioned this yesterday, that don't even believe in tongue ties or think that it's an easy way out for lactation consultants, and we just diagnose tongue ties all the time, and that kind of thing. And it's just not the case. It does contribute to a lot of breastfeeding problems though, like there's, and that just kind of there's like a funnel that occurs by the time babies come to LCs. So again, it's referring to that frenulum under the tongue, and it restricts the tongue's function. A lip tie refers to the frenulum that attaches the lip to the gum line, right? So I have a slight lip tie, or I have a lip tie. And that is why when I smile, I'm super gummy, and my lip kind of gets curled under because that frenulum pulls my lip under. And so those are just some of the things, and so this can definitely impact breastfeeding, in a baby's ability to breastfeed. So kind of the first thing I'll say, around Kaylin's question, which was how do we support someone with a baby with a tongue tie or lip tie? Are there positions, things like that? And I'm just going to be like, no. Like it just has to be fixed.
Yep.
Like it just has to be fixed. There really there really is not anything we can do, because this is, it's, and I don't like to use these words with parents, and so at this point, we're lactation supporters at this table, right, and on this webinar, but you have to think of it as a defect, right? It's a kind of a defect that occurred in development, or the anatomy, or that oral anatomy. And so we just have to treat it if it's causing problems. If it's not causing problems, it's not a tongue tie, right? Like if it's not causing problems, then it's not impeding on the tongue is able to function. That's why we don't go by look. This is why I get really nervous about tongue ties being diagnosed in mom groups,
Oh my
and
gosh,
and things
it's
like
the
that, and
worst.
people just showing pictures. Every once in a while there is a tongue tie that's so obvious that sure, like we can diagnose it by a paper, and I should probably like disclosure here, we can't technically diagnose a tongue tie. That's up to a provider to do.
Is
But
that a state by state rule?
no,
or
it's
is this a
it's our
general?
credential.
Okay.
So it is
Yeah.
within our scope of practice, does
Okay.
not allow for lactation consultants to diagnose anything.
Okay.
But there are cultural differences,
Yeah.
and I don't mean cultural as in like native versus
Like
black.
community
It's community
and
cultural
hospital.
standards.
Yeah.
So
So me in the hospital, I couldn't diagnose, but I can explain it or describe it in my notes
Yep.
and tell a mom, it looks like it may be,
Yes,
tongue restriction, and
and then those moms come to my drop-in
Yeah.
group and say things like, I saw an LC and
Yeah.
she said something about my baby's tongue looked restricted. And then I know that that's hospital LC
Yeah.
talk for tongue tie.
Yeah. Yeah.
Right. And then I can kind of
Yeah.
like go from there.
Some hospitals are good about letting LCs kind of say that, but really technically you're not supposed to say anything. Like we can't even say engorgement. We have to, because that's a diagnosis. We have to say edema. We can't say those things. So I have to be careful. But sometimes if I'm comfortable with a provider, we will say, oh, it's a tongue tie.
Are you allowed to say, I think that your baby needs to be evaluated
That's what
by
you're
a-"
supposed to say.
Okay.
Yeah.
Yep. So kind of the language that I use, because in Seattle, we're LCs kind of run the show when it comes to breastfeeding. And most providers that clip tongue ties or treat tongue ties will not see someone unless an LC has seen them and said, this baby has a tongue tie,
Okay.
kind of thing. I trained at Seattle Breastfeeding Medicine, where it was the LCs. We saw the babies before the doctor and reported to the doctor, and that kind of thing. So where I live, that is pretty much how it goes. But what I say is, like, you need to go to a provider who will confirm the diagnosis, right? And then recommend a treatment, which is usually releasing it, a frenotomy, kind of thing. So yeah, Kaylin, like what I would say is that, like, it, this is something that that typically does need to be treated. And so if you're providing support, because I mean, I'm sure we've helped other Kaylins, but I'm wondering if this is Kaylin from who did our training too in New Mexico. You can tell us if it is Kaylin. I don't
Yeah,
know.
her name sounds really familiar.
Yeah.
Like I've talked to her, or we talked to her before.
Yeah, and I think she had a yes, it's
Yes,
me.
ah.
Yeah. So Kaylin did our New Mexico training and then recently had a baby, and her baby was let me see if I can remember it, Kaylin. S- Steph. It was like a iteration of Stephanie, but it wasn't Stephanie. Stephanie, was that it? Anyway, I was like, all right.
I think I have
Yeah,
her.
so but Kaylin just had a baby, I think, within the last year or two. And so yes.
Yeah.
All
I
right.
think she sent me a picture of her baby.
Yeah,
Yes.
I have like the weirdest
Yeah.
memory. Anyways,
Better than mine.
the things I can remember and
Yes.
not remember. Like I can remember a baby that I met 3 years ago, but I cannot remember to get up in the morning. Okay.
Sure you did
Anyway.
before we were alive.
All right. Yes. And she had Xavier. Yeah. Her son. Okay. So Stephanie is an Indigenous lactation counselor, and so she did our training. And so
Kaylin.
Kaylin, thank you. Sorry. So Kaylin, I'd say like, if you're helping this family and they are resistant to getting their baby's tongue tie clipped, which is definitely really common and babies or parents can definitely, it's hard. Like it's hard to make a decision to do something that is going to hurt your baby, and a release of a tongue tie, and the procedure is called a frenotomy or a frenectomy. Is painful, like it does hurt a baby. But what I often tell parents is that, this will help make your baby's life easier. So it's not so much that like, oh, they're getting by, or I could just bottle feed and it's fine and we don't need to do this. We do see if a baby is having a problem breastfeeding because of the tongue tie, then it is likely that they will have other problems related to the tongue tie as they grow. And so, next will be eating solids, orthodontia, dental cavities, speech and language challenges, um, uh, food sensitivities, like not liking certain textures and things like that, choking. As they get older, it could be neck and shoulder pain. Then reflux, reflux, sleep apnea that's not weight related, things like that, snoring. I mean, there's just kind of like a list of things that, because the tongue is our primary muscle from the shoulders up, so it just impacts so many things in a baby's life or in a human's life. And it's one of those stuff like, when I worked at Seattle Breastfeeding Medicine, and about 90% of our clients were there for tongue ties. Over those like 5 years that I was there, I mean, we would be talking about the challenges that potentially can come. And then you see the parents, like the light bulb going off of like, oh, I have a tongue tie. Like, oh, and that's not normal. Like, you mean, like whatever, right? We had one mom that like really wanted to be a lawyer, but her tongue tie was so tight that she couldn't talk for fast or a long time. And so she became an accountant, and like she literally picked like a different field
because she got tired,
because
right?
her mouth hurt
Yeah.
so much, and she knew
my
she couldn't
gosh.
get in front of a judge and do the lawyer speech and stuff like that. Another mom that had never been able to read her kid like a Dr. Seuss book or something like that because of the rhyming and and her tongue just couldn't work, right? And so then they were like, yeah, clip my tongue too, and we do the parents as well. But Kaylin, if you're providing lactation support or encouragement to this family, just kind of get to them about like what are they worried about. I'm just kind of assuming if they haven't done it yet, haven't clipped it yet, kind of what are they concerned about? And then those are things that you can help talk them through of like, hey, I know it's hard and you don't want to hurt your baby, but this is going to just be that much better for them. And I joke about it, but I'm pretty serious that like babies that are tongue tied, like things like licking ice cream cones and kissing. And, those are things that like all those bad kissers you heard about in high school, like those are tongue-tied bros. Like that's just how it is. They just can't do it.
Yeah.
They can't move their tongue out of their mouth. And it's just not fun. It's just like, blah.
Gross.
So
I like a memory of it. Gross.
you're like, I remember kissing that guy, Brian.
Brian.
Brian Yazzie.
Don't throw names out like that.
I completely made that up.
Or it's be like,
If there really is a
I
Brian
did not-
Yazzie out there, we know that was
that was a made up person. Yazzie is like the Smith of Navajo Nation. So that's why I did it. Brian Yazzie, if you're out there, I did not. I mean,
Caleb's like calling him out. Cora is a made up name. I do have a Brian Yazzie on my Facebook, but it's not him.
Oh my God.
It's not.
Sorry.
Oh my God.
Hilarious. Okay. Yeah. All
Okay,
right.
ours is a Brian Yazzie by community. Oh my gosh.
I'm sorry. Anyway,
there's probably
so-
several of them.
I know.
I'm crying.
There's like 10 Brian Yazzies
Yeah.
in Winter Rock area.
I'm sure they're all great kissers.
And Kimmy and Kim hasn't kissed any of them. We're just
For the record.
putting that out
Not
there.
for a long time anyway.
Oh my God. Cammy, shut up.
Okay, I'm done. I'm done. Anyway, I'm done. Yeah, so okay, I'm sorry. But yeah, so those are some things that you can talk about them with, Kaylin. And then I'm trying to think of like as positions go though.
It would be
I
really
feel like
hard.
if you from a very like I don't know a whole lot about like function and stuff, but to me, thinking off the top of my head, there's nothing that's going to help
Nothing helps
position
you.
wise
Yeah.
because the baby's tongue still can't do
It
what
just
it's
can't
supposed
do
to
it.
do, and
Totally.
it doesn't matter how
Yeah.
Yeah.
Yep.
how you do it. It's still gonna not work
How
or
long-
hurt.
How long did you breastfeed like that, Frankie?
Oh my gosh, I feel like it was like 8 or 10 weeks.
It was painful.
But it was excruciating, and I would just be kind of like how Melissa was talking about, like just for me it was just the first like I don't know, 30 seconds, a minute, and I would be like, okay, you just got to get through the minute, just get through the minute, and then then it doesn't hurt anymore.
Right.
So yeah, it was like 8 or 10 weeks, something like that, because I feel like at his 3-month checkup is when he started his growth
Yeah.
his growth chart went whoosh, or curve,
Yeah.
because he finally
was
he was
able
in the
to-
1 percentile for
Oh.
weight
So he was
for his whole
limiting
time.
his feeding.
Yep.
And then
Yeah,
Yeah.
because that is common
Yeah.
for babies
Yep.
that are tongue tied because they
he
just
can't pull milk out
and
efficiently.
they fatigue so
Yep.
quickly, so
Yep.
their little jaw starts to quiver,
Mhm.
kind of like that, like after you work out and
Yeah.
you sit down and your leg like starts
Shakes.
shaking,
Yeah.
that's like
Yeah.
sewing machine leg,
Yeah.
like a chin, you'll see that with the baby. So when their chins kind of quiver, that's fatigue. And so, and this is where like a lot of times we have kind of, I call them martyr mamas, but our parents that are just like, I'm good, like I'll just deal with this. And I'm like, and I always say like, no, this is actually making things harder for your baby,
Yeah.
and that can be the language. If you have a parent you're working with that just doesn't really care about themselves and making breastfeeding easier for them, then you need to bring it to the baby and say like, this is going to make it easier for your baby to get milk. They're working twice as hard to get half as much milk out.
Yep.
If you move forward with clipping the tongue tie or releasing that tongue tie, then it's gonna they're just gonna do that much better. It's gonna be that much easier for them to get milk, and just throughout their life it's gonna be
It's gonna
like
be
better.
Yeah. So yeah. Just how long does a healing time for the
for the
procedure?
procedure. So it's healing happens pretty quickly. So the mouth in general, mouth and nipples heal really quick. Kind of like once damage is done, just from an evolutionary standpoint, like it's important that those things not have wounds in them, kind of thing. So the mouth heals really quick, especially after, for an infant who's getting breast milk, because they're also like mouth washing with human milk, which is filled with white blood cells and antibodies and kind of these healing components, right? And so actually what we end up doing, or what typically in every provider is different, but most preferred providers for frenotomies are going to recommend doing some exercises. That's what we call them, exercises.
It's torture.
After like after a tongue tie release. And what that is actually slowing down the healing process. So it's kind of doing this like 2 steps forward, 1 step back thing, because a baby uses their tongue. So when we release a tongue tie, it leaves a wound under the tongue that's typically diamond shaped. And it depends on how big it is, but it's a diamond shape. And then when the baby's nursing, right, they're using their tongue and it's putting stretch on that wound and things like that. And then they go to sleep. And for 2 hours, the tongue's not being used, right? And it immediately starts healing.
Just reattaching.
It starts to, because we have this diamond, and then they go to sleep and they're not using their tongue, and it's down like this, and the mouth heals so quickly that it's going to start to heal in that way. And so that's why we typically recommend, and again, this varies from provider to provider, doing exercises 5 to 7 times a day for several days, up to, a week. I've actually seen online, like lots of providers in some of like the tongue tie groups saying like do exercises for 7 weeks or 6 weeks. I'm like, dude, like that was way that's healed.
So about 2 weeks.
Yeah,
maybe
probably like
max.
2 weeks max before it's going to be healed, so but again, that's up to the provider. Technically, we don't get to make those decisions. I'm just going based off of the recommendations that we were making at our breastfeeding clinic. So so that it starts to heal down. And so then we recommend, or typically the exercises are kind of like pushing on that wound and lifting the tongue up, kind of reopening it every couple hours so that it stays open, and then new skin cells will grow in, and that diamond will get smaller and smaller and smaller in this direction, not in a line, like not straight down. So that's kind of like how it is. It should take, baby is going to feel usually significantly better within a couple days, but then those stretches usually have to occur for another week or 2 after the procedure. It is. And so I know for my clinic that I worked at, we recommended routinely medicating the babies with Tylenol, or if they were old enough, ibuprofen. You could even alternate those things. And because if we have a baby that's in pain, they're not going to use their tongue, right? They're not going to put stretch on it. They're going to kind of go shallow. They're going to keep doing, because babies are super smart. So if we have a baby that is being given pain medication, then they're going to be able to put stretch on their tongue. They're going to be able to, they'll be ready to eat, things like that. And so that's usually a part of it. But again, that's something that the provider will hopefully recommend, and there's usually a list. I think, if I remember correctly, I think Kaylin moved to North Carolina because Kaylin's like BFFs with Brittany.
Oh, really?
Yeah.
Okay.
Yeah.
Oh.
And so I don't know. I feel like you were moving down there or something, Kaylin. I don't know. But anyhow, like if this is someone local or in another area, there's usually a list of preferred providers that's out there. You can reach out to other lactation consultants, in the area, and say like, who do we go to for a tongue tie release? That kind of, she's in Cherokee.
Yeah, we have some contacts there that we can also help
in North Carolina. Yeah,
to
if it's a
refer.
local parent.
Yeah.
So you can always just message us if you're not getting much, from anyone locally. But it's important that people go to a preferred provider, someone that's been vetted, that kind of stuff, because that'll prevent additional, a need for additional clips, things like that. Because you don't want to do it more than once. Like that's kind of a bummer.
Yeah.
But yeah. That's about it.
Yeah. Was that helpful, Kaylin? the information that
Awesome.
Cami shared with you.
Laser versus, hi, Jacqueline.
Okay.
Laser versus clipping. So this is definitely like another kind of tongue tie controversy. So there's two ways to do a frenotomy or phenectomy. One is with scissors, and that's usually when we say clipping is
So
referring to
scissors, yeah.
scissors, surgical scissors, and then there's a laser, which if anyone, I know I had never seen a laser used in medical care until I saw my nephews. My nephew went to Dr. Deharry, who's kind of another famous like tongue tie provider, tongue tie
Mm-hmm.
release provider. Um, and he let me come in for my nephew's frenotomy because I had never seen a laser frenotomy before. I trained under someone that used scissors, and so a laser in the medical field kind of looks like a pin with like a bright red kind of ballpoint
Mm-hmm.
thing on the end of it, and that's how it is. So I literally in my head was thinking like Star Wars lasers, so that's not what it's like. um anyway, I was like, oh, interesting,
Yeah.
that's what it is. So there's definitely like you have folks in the field that really say like lasers are better, clips are better. Actually, I should say this. Most people say lasers are better. You don't have people saying like no clippings better, or
Yeah.
anything like that. But the things that I see out in community, so parents talking about why they like laser better, is they say there's no bleeding. They say it doesn't hurt as much as clipping. They say it heals faster, that kind of stuff. I will tell you that is not true. It is not true at all. So it absolutely hurts. The one laser frenotomy that I saw, which was my nephew, was painful to watch. I have never so badly like wanted to grab a baby and
Mm-hmm.
run away with them. Because it took like 30 to 45 seconds,
Mm.
because you're literally kind of like burning at that burning away that tissue with the laser, versus a clip is about a maybe 2 to 5 second procedure.
Do they give any pain meds or
Anesthesia?
anything?
No, I mean, it's similar
Mm-mm.
to scissors. So I mean, like the shot of a pain med is going to be just as
Just as
painful as the
painful.
clip,
Mm.
kind of thing. So in general, and then we want the baby to use their tongue, and you don't want it numb, afterward anyway.
Mm-hmm.
We would do pain meds for older kids, like do a topical lidocaine
Mm-hmm.
for older kids and for adults, but not for an infant.
Yeah.
And so I will say like a laser, it still hurts, and it actually takes quite a bit longer, which was hard to watch. um and and I know 30 to 45 seconds is not very long in the scheme of things, but it was just
That's a long time.
it felt like 5 minutes.
Yeah.
Like I will say, like having my little nephew being the one doing it, like it felt like a long
Yeah.
time, and at that point I had probably assisted on maybe 1,000 frenotomies,
Yeah.
with scissors. And so I was just like, oh my gosh, this is intense to watch. So it's, it does hurt. It absolutely does bleed. And the aftercare is the exact same as
Yeah.
after scissors.
Yeah.
So I personally do not see any difference in the two. I don't see any benefit over, one versus the other, aside from the time that the procedure takes. Because you still have to do all the things. I could see a benefit of laser for a lip tie over a scissors, and that's just because of the frenulum on the lip is a different. It's just a different. I mean, it's like skin.
Yeah.
It's just kind of a different tissue than under the tongue, and so typically, if you clip that, it's still going to leave some tissue, and you might like even like I tore mine at some point, and I still have like
A
just
little
frenulum. I have
dangly.
like frenulum that's like stuck to my gum,
Yeah.
right? Like even though it's not attached to my lip, which doesn't matter, that much. No one's like looking under my under my lip, but a laser, you could actually like burn that tissue away. And so I could see maybe a benefit there of
Mm-hmm.
doing it. But what it actually boils down to is a skilled provider. So regardless of the tool that they use, you want someone that does this and knows how to do it and does a good job. So in Seattle, I usually give people, I just sent someone a list of preferred providers, and one of them is a laser provider. He's a dentist. And then the others use scissors. And so it's just kind of like however that works out for the family. But I personally do not see
Yeah, I've seen both done.
yeah.
Yeah, mostly clipping in the hospital because
Yeah.
like right after birth or not right after birth, but just like a day after birth, you definitely see like the type 1,
Yeah,
family
you're
member
like,
just
we're
clip
gonna
it.
clip
Yeah,
it.
yeah,
Mm-hmm.
yeah. Those are tricky too because sometimes it can't get deep enough. It might be something more deeper.
Totally.
Yeah, and that's the
Yeah.
hard part is
Yeah.
what does baby do
Yeah.
afterwards and how do you,
Yeah.
fix that? to get
Yeah,
deeper?
for like those anterior, like Kim said, type 1 tongue ties that are like tip of the tongue to the gum line that they might clip in a hospital. Like those are tongue ties that
It's
like
just
I
shallow
could
Yeah,
clip.
yeah.
We don't,
Mhm.
but like you could just clip it and we're still not going to go deep enough, and so that tends
Yeah.
to be what happens in the hospitals or like home birth midwives that clip tongue ties. I've seen a lot of those just aren't deep enough because you
Mm.
actually have to go to the base of the tongue. You have to leave a wound, like there
Yeah.
has to be that diamond wound, and you're working around anatomy. There's salivary glands, there's just things you have to be really comfortable working
Yeah.
in an infant's mouth. And that's why going to a skilled provider makes all the difference, because if they're not comfortable with that, then they're not going to go deep enough. And then the baby is going to continue to have problems, whatever, or they're going to need a second clip.
Yep.
So, yeah.
Good question.
Good questions. Good questions.
Yeah.
All right. Looks like we are
Of time.
close to time. So thank you so
Yeah.
much.
That went fast.
Everyone, it did.
Yeah. It's good to see Jacqueline on.
Hi,
People
Jacqueline.
from Arizona, New Mexico
Yeah.
are on the call.
Lots of people. Glad to have you guys here, especially all of you over there on the eastern side of the states. I know it's a little bit early, but not too early for some of you. So
Yeah.
we appreciate you being here. All right. So with that, we are going to wrap it up. We have 2 more sessions today. One is time to get real. Let's talk about how we as healthcare providers are harming Indigenous people. So that'll be interesting. And then
Milk
milk
supply,
supply
making
and
milk,
making
milk
milk.
Yeah.
supply.
Yes.
Yep. That's later this afternoon. Yeah.
So if you know anybody that should be here to listen to these conversations, please share with them the information. It can be found at nooniproject.com. And yeah, we'll see you guys in about half an hour.
Yes.
Thanks for coming.
See y'all later.
Bye,
Toksha.
Mapi.